thank you for the opportunity to invite. So we'll be discussing risk factor modification. So I think we all feel like we work hard, and I'm sure that we all do, but I think we need to ask the same of our patients. These are my disclosures, none of which are actually really too pertinent to this talk. Every year at SAGES and at the ACS and at the AHS meetings, this room is always packed, and it's packed because hernias are an incredibly common problem. So in 2006, about 10 years ago, roughly 350,000 ventral hernia repairs were performed in the U.S. That number has probably increased over the last decade. But not only are we fixing primary ventral hernias, we're also making hernias as we operate on regular patients, doing just primary laparotomies with a rate of incisional hernia formation of around 20%. And with about 2 million laparotomies performed annually in the U.S., we end up creating more than 90,000 hernias our own. And recurrence rates, as we all know, after that initial repair range anywhere from 10 to up to 53%. These rates are going to continue to increase as the obesity epidemic increases, with the increasing longevity of the population, the high initial incidence of hernia formation, and a high recurrence rate after hernia repair. So I think a lot of us kind of feel like we're performing a fool's errand like Sisyphus, just carrying a rock up a hill only to have it roll back down later that day. And so what can we do to break this cycle of repair and then recurrence? I think there are a couple of options. I always think that I could probably transfer my patients to a better surgeon, so I could send them to Cleveland or Kentucky or anywhere else that's not the University of Wisconsin. We could find a better technique, and I think we've added a lot of new techniques to our armamentarium over the last several years, many of which have been extremely beneficial in repair of ventral hernias. We can find a better device, or we can have industry work to make a better mesh, something that's going to be more resistant to recurrence. But more importantly, I think we can work to get a better patient. And by that, I mean we have to modify their risk factors preoperatively before we operate on them so that they'll have better outcomes when we finally do. And when I counsel patients about this in my clinic, I talk to them about their risk factors. And I think about risk factors as either the modifiable group or the non-modifiable group. And for me, the modifiable risk factors, the big three, are smoking, diabetes, and obesity. And then also their nutritional state and their MRSA status. The non-modifiable risk factors are immunosuppressants. We have a huge transplant population in my neck of the woods, and so all of those people are stuck on immunosuppressants. There's nothing that we can really do to get them off of it. Their number of prior repairs, which is clearly an elevated risk factor for recurrence, and the fact that they either had a previous wound or mesh infection or some active infection. Those to me are non-modifiable risk factors, and those you kind of have to take as you go. But we're going to focus largely on the column here on the left. So smoking. Interestingly, the effect of a single cigarette, so this is just one cigarette, and then if you measure cutaneous blood flow in the hand via laser Doppler, that single cigarette leads to a 38% reduction in skin perfusion in smokers and a 28% reduction in skin perfusion in non-smokers. And it takes about 5 minutes for smokers to recover their skin perfusion and about 2 minutes for non-smokers. And that's just a single cigarette. Most of our patients are smoking 20 of those a day at least. So it is a huge risk factor and a huge problem for cutaneous blood flow and then wound complications to follow. When you look at the effect that smoking has on wound healing, smoking is associated with decreased tissue oxygenation and aerobic metabolism. It attenuates the inflammatory healing response and creates a differential in the release of proteolytic enzymes so that the inhibitors of proteolysis are increased. So proteins basically break down a little bit faster than they should in non-smokers, and it blunts the proliferative response. When patients quit smoking, some of those things revert back to normal and some of them don't. So smoking cessation leads to a rapid restoration of tissue oxygenation and metabolism, but that proliferative response remains impaired even after 4 weeks. So smoking cessation for 4 weeks is clearly good, but they never go back to normal. They're always going to be at higher risk for wound complications even if you do get them to quit. Nicotine replacement does lead to some attenuation of the inflammatory response and healing response, but not as much as we see in active smokers. If you're going to counsel your patients about what they should do, if they can go to nicotine replacement, that's clearly better. If they can quit for about 4 weeks, that's probably the best. If they're a non-smoker, obviously that's the best possible status. In another meta-analysis that looked at 140 studies and about 500,000 patients, smokers had elevated risk factors of tissue necrosis, wound dehiscence, SSI formation, hernia recurrence, and elevated wound complications. And smoking cessation reduced SSI, but none of the others. So again, if they're going to quit, and they should, for about 4 weeks, they're going to improve their risk of surgical site infection, but a lot of their other risks are going to remain elevated, and they should be counseled as such. In looking at diabetes, this is a nice study that looked at 306 patients undergoing retrorectus repair of abdominal wall hernias, and they found that their major risk factors for recurrence and failure of their repair was number 1, diabetes, number 2, hernia width, and then number 3, biologic mesh. And some of the better data on diabetes actually comes from cardiac surgery. And this was a study where they looked at 1,000 patients undergoing cardiothoracic operations, usually via midline sternotomy, and the rates of wound complications increased with the presence and preoperative control as well as post-operative control of diabetes. So non-diabetics had an SSI risk of 1.5%, whereas all diabetics had an elevated risk up to 5.8%. And when they differentiated them by poorly controlled to non-poorly controlled, and they used a cutoff of a hemoglobin A1C of 8, they found that those that had a hemoglobin A1C of greater than 8 had about an 8% risk of SSI, and those that were less than 8 had a 4% risk. So glucose control is very important both in the pre, peri, and post-operative periods. Obesity, as we all know, is a huge epidemic in the United States and really worldwide in many other countries. This was a nice study that looked at a regional database review of about 26,000 patients with ventral hernias without incarceration over a 3-year period. And compared to patients with a normal BMI, the odds of hernia increased very, very clearly and very linearly with elevated BMIs. So overweight patients had a 1.6 increase in risk all the way up to a 5% increase, a 5 times increase in risk for patients with a BMI of greater than 60. So obesity is a major problem for our patients, as we all know. And in fact, it's probably the number 1 modifiable risk factor. This was a study from Case and Urinovitzky and Mike Rosen's group where they looked at 88 patients with ventral hernia working group, grade 2 hernias who all underwent repair. And they had an SSI rate of about 13%. And those predictors on univariate analysis were operative time, ASA score, the presence of COPD, and not surprisingly, BMI. And as we all know, once you get an SSI and a ventral hernia repair, you're pretty much stuck with a recurrence to quickly follow. So what do I do in my practice? I make all my patients quit smoking, and I won't operate on them unless they do. I test them all for nicotine and cotinine at 2 weeks prior to surgery. They could probably then smoke the next week or two and lie to me, and I would end up operating on them. I do ask them. I've had a couple fess up the truth, and we've canceled surgery the day of the case. But I test them 2 weeks prior because for us it's a mail-out test, so I can't do it the day of. But I think if you did it the day of, that would probably be better. But we mandate smoking cessation 4 weeks prior to surgery. I won't operate again on anyone with a hemoglobin A1C greater than 8. If we can get it less than 7.2, that's probably even better, and that's data from Todd Henneford's group. But I have a hard stop and a hard cutoff at 8. And then for BMI, I use 40. I think a lot of other people use 35. I think in Wisconsin, I probably wouldn't operate on anyone if I had to get their BMI under 35. My BMI is barely under 35, so I probably wouldn't be operated on anyway. And I have found that the CeDAR app is one of, I think, the most useful things in counseling patients about this problem. So for those who don't know, this is the Carolina's equation for determining associated risks. And this is an app that you can download on iPad, iPhone, or Android. And it basically asks you to put in several data points about your patients. And I do this right in front of them. So do they have uncontrolled diabetes? No. Does the patient use tobacco? Yes. Have they had a previous hernia repair? Are we thinking about violating the GI tract, or is there a stoma in this patient? Is there an active infection? Do they have concomitant skin or subcutaneous advancement flaps? So are we raising big flaps to do either a paniculectomy or potentially an onlay? And are they going to have a component separation? And then you enter in their height and their weight, and those are actually not my height and weight, only because I think I've probably gained another 5 pounds since I made this slide a couple weeks ago. And it spits out this. So it shows what their overall risk of complications are, what their in-hospital charges are going to be, and what their follow-up charges are going to be. And so it puts this in real terms that patients can understand because they see the dollar signs. And that, I think, makes sense to them. You can then go back and edit these right in front of them. So you could say, look at what happens if you quit smoking, and their risk goes from 68% to 53%, and their charges drop. And so this is, I think, a very powerful and helpful tool when you're counseling patients in your clinic. The last two things that I think are modifiable risk factors that we've introduced in our program as well is, number one is immunonutrition. And so this is IMPACT, which is an enteral formula that contains arginine, some dietary nucleotides, and omega-3 fatty acids. And patients are instructed to drink 3 of these a day for the 5 days leading up to surgery. And there's actually a lot of good data on this product, and it comes largely from surgical oncology procedures. But in one meta-analysis of about 35 randomized controlled trials, they found a 41% reduction in infectious complications in all postoperative patients who used IMPACT. And they actually had a decreased length of stay to go along with it. So I think it's a useful product. We do give it to our patients that are going to undergo open or complex abdominal wall reconstructions, and we ask them to drink it for 3 days prior, or for 5 days prior to surgery. And I think the last modifiable risk factor that we tend to see is MRSA, or Staph aureus infection. And there's a couple New England Journal articles that have looked at this as well. And so this is a randomized, double-blind, placebo-controlled trial of about 6,700 patients, largely undergoing orthopedic procedures, who were treated and cleared of Staph aureus prior to surgery. And they did this by combining 5 days of Bactroban, or mupirocin ointment, and chlorhexidine gluconate soap. So they take a HibiCleanse shower and they rub Bactroban on themselves for about 5 days leading up to surgery. And with that protocol, they found a 44% decrease in SSI. So the question becomes, all right, so that's a pretty remarkable effect, and we should probably be doing that on most of our patients, but who should we actually do it on? And there was a nice study in another journal, the New England Journal episode, that showed that they rate basically in ICUs assign patients to 3 different treatment protocols. So in ICUs, they either screened them and isolated them like we all do in our ICUs. So if they screened positive for MRSA, they were isolated. They went on to a targeted decolonization, so they would screen them. If they screened positive, they then got the Bactroban and HibiCleanse showers. Or they did universal decolonization. They didn't screen, they just treated everyone with that protocol. And what they found was that the risk of bloodstream infection with any pathogen, not just Staph aureus, but any pathogen, was significantly decreased with both of the decolonization protocols, but decreased more and better by the universal decolonization. So essentially, just treat everyone. You don't even need to screen them. I would just treat them. It's a pretty low-risk intervention and can have some pretty significant benefits and results. So we work hard, but I think we need to ask the same of our patients. And if they're going to undergo a big operation, they need to really be maximized and optimized for it. So make them quit smoking. They got to quit for about 4 weeks prior to surgery to get all the benefit of smoking cessation. Get them to lose a little bit of weight, either through a modified diet or through bariatric surgery if necessary. Get their blood glucose under better control. And then I think a couple of easy interventions are start giving them IMPACT and kill every Staph aureus that you can possibly see. And I would recommend that everyone really download that CeDAR app. I think it's a very, very helpful tool in counseling your patients. And then lastly, I would just make a plug for the AHS QC. These are difficult cases, difficult patients. We need to figure out how to operate on them better and to learn together. And I think the AHS QC is a great vehicle for us to do that. Thank you.